Let's discuss neonatal hyperbilirubinemia. Bilirubin is one of the end products of hemoglobin breakdown. Hemoglobin is broken down via intermediate steps to bilirubin and released into the systemic circulation. Bilirubin binds to albumin and is transported to the liver, where it is conjugated, which makes it more soluble. It then enters the enterohepatic circulation, where it is excreted through the biliary system into the GI tract. Bacteria in the intestine unconjugate the bilirubin, converting some to urobilin, which is excreted in the urine. The bulk of the remaining unconjugated bilirubin is reabsorbed, with the remainder excreted in the stool. In infants, there are several physiologic changes in hemoglobin and bilirubin metabolism. These include increased hemoglobin production. Neonatal red blood cells have a shorter lifespan than adult red blood cells, so the turnover is more rapid. Polycythemia. A hematocrit of 50 to 60 in the early postnatal period is common. More blood cells with a shorter lifespan means more breakdown in hemoglobin release. These two changes result in bilirubin production 2 to 3 times that of an adult. There is impaired bilirubin clearance. The liver enzyme that conjugates bilirubin is immature in neonates. In the first week of life, this enzyme has only 1% of adult function. The enterohepatic circulation of bilirubin is increased in neonates, so more bilirubin is reabsorbed from the GI tract. These each contribute to the benign physiologic jaundice that is present in most neonates, which resolves spontaneously as the infant's bilirubin metabolism matures. Additional alterations to bilirubin metabolism can result in severe hyperbilirubinemia. These alterations include increased bilirubin production, impaired clearance, and increased enterohepatic circulation. First, increased red blood cell turnover. Causes include isoimmune hemolytic anemia due to Rh or ABO incompatibility. Cephalohematoma or birth trauma creates a reservoir of red blood cells that are eventually broken down. Polycythemia, like in macrosomic infants of a diabetic mother. And more rare are red blood cell membrane defects, like hereditary spherocytosis, and enzyme deficiencies like G6PD. These each result in jaundice in the first days of life. Next, impaired bilirubin clearance. The liver enzyme that conjugates bilirubin can itself be impaired either by decreased production, Gilbert's, or impaired function, Crigler-Najjar. Congenital metabolic defects, like galactosemia or congenital hypothyroidism, can also impair clearance. Jaundice from these typically develops after the first week of life. Finally, increased enterohepatic circulation, including breast milk jaundice, obstruction, and breastfeeding failure jaundice. Breast milk jaundice is benign and due to breast milk containing a compound that increases bilirubin reabsorption. Obstruction, including atresia, meconium ileus, stenosis, means stool is not formed or passed correctly, and bilirubin absorption increases. Breastfeeding failure jaundice is poor oral intake in breastfed infants due to maternal factors like poor milk production or neonatal factors like impaired suck and poor latch. Jaundice is monitored closely due to the potential for neurologic damage, referred to as bilirubin-induced neurologic dysfunction. When total bilirubin is dangerously elevated, albumin becomes saturated, and circulating bilirubin may cross the blood-brain barrier, resulting in cell apoptosis and necrosis. Acute bilirubin encephalopathy ensues, with early signs and symptoms including hypotonia, somnolence, and a high-pitched cry, that can progress, if untreated, to hypertonia, fever, seizure, lethargy, and even coma. The chronic, irreversible sequelae of neurologic injury is called kernicterus. This develops in the first year of life and tends to spare most cognitive function. It results in sensory neural hearing loss, chorioathetoid cerebral palsy, and gaze abnormalities. Close monitoring of serum bilirubin is critical for proper treatment. Bilirubin is checked 24 to 48 hours after birth, and earlier if isoimmune anemia is present. Bilirubin levels are plotted on 2 nomograms. The first is a risk assessment. Based on your current total bilirubin, what is the likelihood that this infant will have a future total bilirubin greater than the 95th percentile? Risk groups are high, high intermediate, low intermediate, and low. This informs the physician of how soon the next bilirubin level should be checked. Concerning bilirubin levels are those greater than the 95th percentile or a rate of bilirubin rise greater than 0.2. The second nomogram is for starting treatment and classifies neonates based on gestational age and risk for developing severe hyperbilirubinemia. Major risk factors include a high-risk bilirubin, jaundice in the first 24 hours, Rh or ABO incompatibility, G6PD, spherocytosis, cephalohematoma, weight loss greater than 12%, a sibling who received phototherapy, and late preterm 35 to 36 weeks gestation. The bilirubin level is plotted on this nomogram, which advises practitioners of when to start phototherapy or if exchange transfusion is indicated. In phototherapy, light from the blue-green spectrum crosses the skin and causes irreversible bilirubin isomerization to lumirubin, a more soluble form that is excreted in the stool and urine, promoting a gradual clearance of bilirubin. Exchange transfusion is used in severe cases to rapidly reduce circulating bilirubin levels.